Thank you very much, Dr. Langley and Dr. Wong. Very interesting material. We do have 4 questions, 4 very good questions, and that I can read off for you. Just a quick reminder, the PowerPoint as well as the audio and visual of this webinar will be made available within 2 or so weeks on our website, Safe Start Center, our Safe Start Center website. So if you don't mind, I'll just read one question and we'll go from there. Okay?
Uh-huh.
Okay. So the first question was, could the presenter share information on costs and needs for staff, resource needs, staffing? Yeah, that was the question.
I can start, and then Marleen can jump in. I think that it's going to depend on what type of program your writing and your plans offer. So I don't know if there was anything specific in mind, but as you're researching that particular program, I would really encourage you to get that definitive information about really the time, because the costs are going to vary from community to community, but figuring out the amount of time that you will need on hand in order to implement the program. And then, again, I would just encourage you also to be conservative in that.
Yeah, excellent. And if there's more individualized questions, of course, we can get those to you after the webinar, and you can address them more directly. The next question.
Andrew, can I just add something?
Yes, of course. I'm sorry. Yes.
Sure. Not quite sure which cost you're talking about, if it's a school-based mental health program or if it's specifically to implement an evidence-based intervention. But I concur with Audra that it depends on your community. But you can also augment that and reduce some costs. If you have second-year graduate students in social work or doctoral students in psychology, et cetera, because if they're trained early in the year, particularly if they're trained in a specific intervention prior to their entry into their internships, they can also provide extra manpower for with licensed supervision for the provision of these services.
Great. The next question was, how do you implement across a system rather than just one school?
Well, I can speak to that. First, it really is a commitment of years. When we started this work with RAND and UCLA, and I was at LA Unified School District, once that seminal article on CBITS came out in the American Journal, the American Medical Association, in JAMA, it took us, we had to have a core, kind of to build slowly, a core of, and we used a trainers model. So to have a core of people who could be trainers, who really have had the experience of running groups, who have been supervised by someone who is trained, that just takes time. And you need stability in the program so that those people are continue to be available to you. So, at this point in time in LA Unified, there are now probably a core of maybe 8 to 10 people who could possibly train other people and students and provide supervision. And there probably are closer to over 100 that are actually implementing. But it's taken us several years to get to that point. It's not something that can happen overnight.
I would say that sometimes if you are wanting to go in at a district level, it also can be very helpful. So if that happens, it really is starting to talk with someone at the district level. Ultimately, it has to be approved by the superintendent, but usually you're talking to someone like a Safe Schools officer or a director of pupil services or a director of specialized programs or someone like that, who would be working with the type of program that you're interested in providing. And oftentimes, I think, like Marleen said, it does sometimes take longer, but it's building buy-in and establishing yourself there, and then it's starting to do these professional developments for all of the different groups of people in the district who the district calls for these quorums or for these professional developments. And the other thing that can be helpful is sometimes these people in the district are able to help you select the best schools, or the schools that maybe either have the most need, have the highest prevalence of the population that you're hoping to serve, or who have the principals who they know would be on board or have been successful with similar programs. So they can be helpful in identifying then where you would sort of start your program if you wanted to. So I'm not sure if someone's talking about really kind of a district level prevention that's just training to educators, or, so it's a little hard for me to know exactly what kind of program it is, but I think that working with the district is possible and definitely can be helpful.
Yeah, and I think Audra brings up a good point in terms of tailoring messages and presentations to different constituencies, because even though you'll be working perhaps with a certain grade level or a certain group of students in a particular school, it's always important to be able to present to parents what this is about, a different presentation to teachers, what do the nurses need to know, what do the administrators need to know, etc. So that's all part of entering into a school and preparing the foundation for your participation in a school mental health program.
Okay, the next question. What if an entire school population is traumatized? How do you select what students participate?
That's a great question. Marleen, do you want to start?
Well, I'll start. Audra's really the expert in the intervention and that particular question, but I'll say as a person who, was about in the early years when we tried to start this, we could only assess the number of students that we could possibly treat, because you could do a screen of the whole school, you could survey the whole school, but then if all of these students emerge, then you have to find a way to treat all of them. So what we did was we decided, even in a school, we would go into a school and we'd say to the principal, do you think this program could be helpful to you? And if the principal said no, we didn't go to that school. Okay, so if the principal said yes, we went to the teachers and asked them the same questions. And if the majority of teachers said no, we didn't go to that school. If the majority of teachers said yes, we went down to the students and the parents. And so we selected those classrooms in which the teachers were most enthusiastic and felt that they really could understand what we were saying. They recognized the symptoms that the children had. They really wanted us to be there, and we started with those classrooms. And we only assessed those classrooms, and then we treated. And it wasn't until we finished groups for that classroom that we moved on to another classroom. So we really looked at the staff we had and approached it in that kind of planful way, because that is such a great question. You don't want to identify all these kids and then there's not enough people to treat them.
Also, again, it's tough with this with doing the questions in this format, because the question could also be interpreted as, if it was sort of like a violent event that occurred at the school that everyone was impacted by. What usually happens is up front, as Marleen said, these crisis teams do kind of swoop in and provide this type of psychological first aid and crisis response and stabilization. And so that's something that's typically offered to everyone who's been impacted in the school. Now, a few months later, PTSD is not something that's diagnosed initially. So a few months later, a majority of those students will be back to a stable level of functioning. And that's when you would then identify to the ability of the number of students you're able to serve. That's when you would want to go in and start looking at who the students are that are continuing to have symptomatology. And those are the ones you would want to address with an early intervention or, some type of a targeted intervention program. So I guess the point is, even if everybody is impacted by, for example, an event of school violence, not all of those students will then go down the road of being symptomatic. There is sort of a normal level of recovery following an event.
Okay. Great. And next question. Can schools bill insurance for cognitive behavioral intervention for trauma in schools or other interventions?
I'm going to answer that yes, most definitely. But LA Unified School District was unique in that it had one of the first Medicaid contracts with the Los Angeles County Department of Mental Health, and we became one of their contract agencies. And we had initially three clinics across our school district that met. We had to go through all of the regulatory reviews, and it took us 3 years to become certified, but we finally did. And within that context, actually, the State Department of Mental Health in California recognizes CBITS as an evidence-based practice, and all clinics as well as schools who have these kinds of contractual relationships can bill for it. So it depends upon your locality and the kind of billing that the school district does.
Yeah, that's absolutely true. I mean, there are agencies who co-locate into schools and bill for those services either through private insurance or through Medicaid. So again, it depends on what type of agency contracts are set up, as well as if they're school-based, what types of school-based. But it certainly is possible, and not only that, but it's something that's being done.
Okay, that's all the questions we have over here. If Elena or if either you, Dr. Langley or Dr. Wong, if you have some kind of typical questions that you usually get, or this is now is a good time.
This is Elena. I don't have a typical question. I just wanted to add to the list of resources that Audra provided, the issue brief that both Audra and Marleen wrote for the Safe Start Center, and which can be found in our website. And that's a very useful summary of several of the things that Audra and Marleen mentioned today. That's all. Thank you.